So why don't we shift a little bit and talk about disparities in IBD care? So we see disparities in many different diseases, and unfortunately, IBD is not immune to disparities. For instance, Black patients with IBD have 3 times increased ratio of IBD hospitalizations and mortality in comparison to white and Hispanic patients. As well, that patients with low socioeconomic status have an incidence rate of IBD hospitalization that's 4 times higher than those who are higher socioeconomic status. Also, Black patients are less likely to receive preventive care in IBD, including DEXA scans, ophthalmologic examinations, flu vaccinations, and cervical cancer screening. And Black patients are less likely than white patients to be under the regular care of a gastroenterologist or an IBD specialist.
And if we look at clinical trials, of course, we
Yeah.
see they're predominantly in white patients.
Yeah.
So there's also a paucity of data to tell us whether they're more or less likely to respond to some of our treatments.
Absolutely. And oftentimes race actually isn't even mentioned in some of the. All right, now let's talk a little bit about low socioeconomic status in IBD. So this is a population-based study out of Canada. It was about 10,000 patients. And it's really important to remember here that Canada has universal healthcare. So theoretically, everybody should be able to access the healthcare system. In this study, low socioeconomic status was associated with more use of any IBD medication except biologics. And it was also associated with worse outcomes like more hospitalizations, ICU admissions, frequent high-dose steroid usage, as well as higher mortality rates. Now let's talk a little bit about continuity of care in IBD. So this was a retrospective study out of the VA looking at about 20,000 US veterans across the nation. So in this study, a low level of continuity of care was associated with more surgery, more hospitalizations, and more corticosteroid usage. So now let's pause for a second. So in our earlier slide, we saw that Black patients are less likely to be seen by a gastroenterologist regularly. Now we see that continuity of care is associated with worse outcomes in IBD, and low socioeconomic status as well is associated with worse outcomes. So it's really important to think about the patient in front of you, think about all of these factors, and think about some of the barriers that they might be facing and how you can potentially intervene early.
Adjoa, one of our colleagues is asking, is this due to biased delivery of care, or is it due to lack of access to care?
You know, that's a really interesting question. And we actually don't have any data looking at bias in IBD. I think it could be a combination of the two. For the Canadian study, it's obviously not an access issue because everybody has health insurance there. So that could theoretically be more of a bias issue, but it's not really discussed in detail in the paper itself. In terms of the continuity of care in IBD, not being under the regular care of a gastroenterologist or an IBD specialist in the US, well, at the VA, everybody has coverage as well. It doesn't seem as much to be an access issue, but whether it's a bias issue, we don't have the information.
Yeah, I think it's important in Canada, it's sort of adjusted for access, but still the patients were less likely to receive biologics. Mm-hmm. So certainly, and that was a socioeconomic status group compared to different racial groups. Yeah. Okay, keep going.
So now let's shift a little bit and talk about social support in IBD. So social support correlates with better self-management behaviors in IBD. Models that include patient and provider education and care management have success in improving patient outcomes. And case management to assist patients in navigating the healthcare system has shown benefits in improving care. And we've seen similar findings with patient navigation having an improvement in care, particularly in cancers like colorectal cancer or breast cancer. Now let's shift a little bit and talk about experiences of minority patients with IBD. Now I'm going to say first that this is not specific to IBD, but many of these are generalizable to minority patients who have interactions in the healthcare system in general. So they might face implicit bias. So implicit bias is defined as associations outside of the conscious awareness that lead to a negative evaluation of a person on the basis of irrelevant characteristics like their race or their gender. They might also have mistrust of the healthcare system. So this stems from decades of discrimination and exploitation of Black patients at the hands of medical providers. So we obviously cannot talk about this in detail right now, but if you are interested in learning more about the historical nature of this, I would suggest that you read more about the Tuskegee syphilis study or you read the book Medical Apartheid. Those will both be helpful in giving you more of a background as to why some patients aren't trusting in the healthcare system. They also might experience stigma and racism. So both actual and perceived racism has been associated with negative health outcomes. So racism is associated with chronic stress. And remember, IBD patients already have stress and anxiety, and they're already at risk for that. So it's associated with chronic stress, which has been tied to hypertension, preterm birth and low birth weight babies in Black mothers, as well as increased mortality in older adults. So racism really has an impact on patients and negative health outcomes overall. They might also experience lack of shared decision-making. So they might feel like their providers are speaking to them or at them or over them, but not necessarily with them. They might have delays in diagnoses where they're presenting over and over again with symptoms suggestive of IBD, but they're not receiving the appropriate workup. Or they might feel isolated. You know, they might not know other people who have their disease. They might not know people who get them or who see them or who understand what they're going through. Right now, there are there's no patient support groups currently specifically for minority patients. And, you know, those can be real sources of support and encouragement and seeing people who understand what you're going through. All right, now let's talk a little bit about implicit bias in healthcare professionals. So I'm gonna start by saying we all have biases. Healthcare professionals have the same level of bias as the general public. And I think what's really important is to, you know, first of all, take something like the implicit association test that can tell you a little bit about your biases, but also every time you're with a patient to think about, you know, how can my biases be playing a role here, and really taking an active role in thinking about your bias, being aware, and really being mindful, particularly when you're with particular patients, about, you know, how implicit bias can be affecting your interaction with that patient. So pro-white, anti-Black physician bias was associated with white patients feeling more respected by their physicians, but Black patients felt less respected. They had lower levels of liking their providers. They were less willing to recommend their provider to someone else, and they felt that their visits were less collaborative overall. This physician bias was also associated with verbal dominance by the physician with Black patients. And pro-white physician bias was associated with Black patients being less likely to even fill their medications or less likely to adhere to your recommendations. And this probably stems from not trusting their physicians because they know that their physicians feel a bias against them. And it's also important to note that for physicians and nurses, implicit attitudes vary greatly from explicit attitudes. So the implicit unconscious biases vary greatly from the, you know, deliberate things that you think about and report.
One of the questions we had here is specifically to me: how do I train my fellows and other faculty? And I'll just say that we have an academic skills retreat annually here, and this past year we invited a speaker from the university who specializes in educating about this topic to teach us about implicit bias. And then for our GI Grand Rounds for our faculty, and we invited all of our staff and nurses as well, we had actually two individuals do an interactive presentation. So clearly learning about this and referring to some of the web resources is helpful. Okay.
That's great.
This is great, Adjoa. Keep going.
All right, so some strategies to empower patients to communicate about their preferences with you. So number one, focus on the present moment. So I think it's really important to ask patients questions like, what matters to you? Or what are you most concerned about today? Or what's bothering you the most today? And oftentimes what the patients are the most concerned about are not necessarily things that we're the most concerned about. But I think it's really important to address their concerns and make them feel like they're being heard. You also want to listen to what patients and caregivers say. You don't want to talk at them or over them or to them, but you really want to have conversations with them and really hear and listen to what they're saying and try to address everything that they're concerned about. You want to ask situational questions. You want to provide information when and where it's needed. I will say that it's really important to speak slowly, to repeat things often, and to not use medical jargon when you're dealing with patients. A lot of times they'll act like they know exactly what you're talking about, but when they get home, they'll realize that maybe they didn't, or even in the room, they know that they don't, but they don't want to tell you that they don't understand what you're saying. So I would say be clear, repeat often, write out instructions, and try not to use medical jargon. And then you really want to create a shared set of goals and check them off together at each appointment, so your patient knows that you guys are on a team and you're working towards the same endpoint. There's some digital tools to empower patients. So there are some decision aids like IBD and Me, which generates a personalized therapy preferences report for patients to discuss with their physician. There are GI symptom trackers like My Therapy or My IBD Manager or My Colitis, which help patients track their symptoms and share this information with their physician. There are other resources for minority patients. There's a new organization called the Color of Crohn's and Chronic Illness. So this is an organization that is specifically targeted towards minority patients with IBD. I want to say that I work with this organization, but I don't receive any funding from them. I'm just very passionate about what their mission is. And they're actually launching the first patient support group for minority patients with IBD, either in November or December. So you can join their, their listserv. And then visit CME Outfitters Gastroenterology Patient Hub to find these and additional resources to share with your patients. And I'm going to pass it back over to David now.
All right. Yeah, I would encourage folks to go to the CME Outfitters Patient Hub, where a lot of these resources we've covered today. Maybe I can convince them as well to post access to the screening tools for mental health as well.
Oh yeah, that'd be great.